Welcome to Life by a Thousand Cuts, a podcast series about skin cancer surgery. I'm your host, Associate Professor Tony Dicker, and in each episode we'll share practical insights to support your skin cancer surgical practice, from clinical tips and case studies to journal reviews and interviews with skin cancer colleagues. Today we are looking at an article in the journal Dermatologic Surgery titled Comparison of 5-O-polypropylene suture and N-butyl 2-octyl cyanoacrylate for closure of surgical wounds on the trunk and extremities, a split scar study. So let's get into it. The study is comparing surface closures with glue versus sutures. This article was published in September of 2025 in the journal and compares two surface closures techniques and then the resultant scars 12 months later. The title caught my attention as I thought, yes, it would be interesting to compare the closure of wounds with glue versus sutures. The study was done at some dermatology clinics in Kentucky and New Jersey in the United States. Its two derm surgeons collected data over an 8-year period between 2014 and 2022, and I must admit that felt like quite a long period to be running the study. And even then, they only managed to collect 100 enrolled patients over that time. So the study was limited to lesions requiring primary closure, and that was to either the trunk or the upper extremities. Their intention was to collect data about these areas, as they'd found that the information was lacking in literature regarding that. Past publications were focused on the head and neck. So head and neck lesions are excluded, and they also excluded lower leg lesions in this study. Other major criteria was that the primary closure was expected to be at least 5 centimetres in length. And I thought that was quite a sensible criteria, as it's usually the longer scars that have a more of an aesthetic impact. So exclusion made sense. Inclusion criteria, they left out the fact that there's other data on the head and neck, so they limited their data to those parts of the body. They also stated that most of their lower leg closures were by secondary intention, which is why it didn't fit the study criteria. Yeah, so sensible other exclusion things like allergy to the adhesives, other scarring in the immediate area, incompleteness of follow-up. If the patient didn't show up, they got excluded from the study. So they couldn't re-photograph and then assess the scar. Now the study is a split scar study. So half of the wound was closed with one technique and then the other half was closed with the other technique. So they're comparing on the same patient side by side. And the side of the scar that was treated, medial lateral or inferior superior, was randomized. So it's a study comparing the surface closure and the resultant scar, but each scar also had some deep dermal sutures. So on the back, they were using 3-O-polydioxane, which you may know the common brand name PDS. And on the trunk and limbs, they used 4-O-polygalactin 910, which you probably know as Vicryl. And I thought this was interesting because they're doing a study about the amount of inflammation and reaction of scars, but Vicryl is known to have a fairly reactive and inflammatory response to it. So I wasn't sure how that itself might have influenced the results. But the assessment was 12 months down the track, so it's well after the Vicryl had dissolved. PDS itself tends to be less reactive than Vicryl. At the same time, because the scars were being compared side by side, the influence of this inflammation should also have been cancelled out. My personal preference, of course, is I use deep sutures as monosin, which tends to be less reactive in the skin, and I presume that would lead to a better scar result, which is why I use that. So I'm not sure how that would alter this sort of study, comparing something like a monosin as a deep suture compared to a Vicryl, but I digress. For the surface and the core of the study, they closed one half of the scar with the polypropylene suture and one half with the cyanoacrylate glue. This way, each scar was its own comparison rather than being influenced by the different healing abilities of different people. A sensible way to design this study, really. Again, I noticed they used Prolene as a suture rather than nylon. It's a little more expensive and it meant to have a superior tensile strength. But in this study, the sutures were removed at day 7, so that wouldn't have had much of an influence. The polypropylene is reported as being less reactive, but I feel that the difference between polypropylene and nylon would have been insignificant compared to the expected reactivity of Vicryl. Often these things come down to clinician habits. It's probably their habit to always use Prolene as their normal suture for surface closures, but that's just a presumption on my part. What are the results is probably the important thing. So the scars are photographed at 12 months, then the images were evaluated by both surgeons and giving a rating between 0 and 13. 0 is the best possible scar and 13 is the worst. And in the end, they didn't find any significant difference between using sutures or glue. Now that grading system they used wasn't just made up for the fun of it. They divided the images in two. Each half of every scar was assessed using the Scar Cosmesis Assessment and Rating Scale, so a SCAR scale. And this measures scar spread, erythema, dyspigmentation, hypertrophy, atrophy, track marks, and also the overall impression. Now that's as good as it can get for what has to be a subjective process in terms of measuring the aesthetics of a scar, but I thought that was quite sensible and real. The only real difference they did note was the rate of track marks. This was 22% with Prolene's side of the scar having track marks compared to 12% of the glue scars having track marks. Now, that bit did confuse me. I'm not sure why any of the scars closed with the glue would have any track marks. And even then, I'm still surprised that they had that many suture marks when the sutures were removed at 7 days. Now, they suggested the track marks may be related to the deep sutures, and I'm going to look out for that with my wounds that I've closed with deep sutures alone. So it's not something I've looked for in the past, I suppose. I'm going to look out for it to see if I can find any evidence of track marks from my deep sutures. The other observation when they're doing their sub-analysis was that the scars tended to look better on the chest with glue versus sutures. So in that one particular area, compared to backs, compared to arms, they noticed a better outcome on chests. And this is certainly a difficult area, and I have seen a couple of keloid scars develop in the middle of the chest. They didn't mention any keloid scarring amongst their results, which is good, but if it's something that can improve chest scars, then it's certainly worth considering. So overall, a nice study with results suggesting that using a glue for a surface closure of a wound when there are deep sutures in place may be an option. It may be given a slightly better long-term aesthetic result, but in their hands, it certainly didn't make things worse. And they agreed that their overall numbers were small, so it's hard to make any interpretations, but it's still good to have this sort of information available in the community despite those limitations. So I can picture how this might be an effective way to add a protective layer on the surface when a wound is closed with deep sutures alone. The downside is it might prevent any serous ooze escaping from the wound. It depends on how the glue is applied. Food for thought. That's all for today. I hope you found this episode helpful and perhaps even picked up something practical to use in your clinical work. A big shout out to HealthCert for all their help with production and distribution of this episode. They do a lot of good things in skin cancer education, including helping to get this podcast to you. Thanks for listening, and I'll see you next time on Life by 1,000 Cuts.